Hi everyone, this is Alia. I'm one of the interns at Nepean Hospital, and today we're going through the approach to the patient with shortness of breath. So in your approach, you would do so as you would with any presenting complaint. This could be a patient showing up in ED or on the ward while you're on evenings or nights, or in an outpatient setting like a GP practice. So as you would each time, you'd go through it systematically with your history, your examination, and your relevant investigations, and really fleshing out the history of presenting complaint with the timing, the onset, their relieving and exacerbating factors, any associated symptoms, etc. And supplementing this with the other parts of the history, like the past medical, medications, family, and the social history, which is quite easy to brush aside, but it can give you very important information. Whether they're a smoker or a non-smoker, have they had a history of travel or sick contacts? Are they compliant with their medications? Do they have fluid restrictions? Are they compliant with that? Do they show up to their follow-up appointments? So it gives you an idea of your patient's potential prognosis and how you might need to manage them moving forward. And then with your examination, as always, starting with your ABCDs and your end of the bed assessment of whether they're well, unwell, or in a critical state, and that's quite important to ascertain early on. With your investigations, being able to justify what you're ordering and why you're doing it is quite key, and you'll gain a lot of information from your history and examination that will allow you to do so. This slide just shows that you can discriminate between different causes of shortness of breath with just history and physical examination findings. So it's really important to do those quite thoroughly. As you are going through your history examination and then starting to work up towards what investigations you want, it's really important to have in mind your list of differentials. And again, having a systematic approach to that will be very helpful and ensure you don't miss out on anything. So what I like to do is divide it into cardiovascular causes, respiratory causes, and then other causes. And you can divide it up however you want, really, as long as you ensure you're keeping track of everything, every possible cause of the patient's presentation. And along with that, it's also important to keep in mind the life-threatening causes that require more urgent attention than others. And that would be a myocardial infarction, a cardiac tamponade, a pulmonary embolism, a tension pneumothorax, or an obstruction of the upper airway. So you'll want to get help very early if these present to you. And what could you do in your capacity as a junior doctor going into the workforce? This talk will be aimed more around the workup of the patient with shortness of breath, but there's also a few management things that will be very helpful for you to know going in. So initially, as always, it's very important to go back to your basics, your ABCDs, see your vital signs, and importantly, remember that you treat as you go along these separate steps. So you're starting with your airways. If your airway is compromised, then we'll need to stop there. Make sure that you do your head tilt and jaw thrust, and ensure their airway is patent before you move on to the rest of things. Once you've ascertained your patient is stable in the initial instant, you can move on to the management of the actual underlying cause of their presentation. So if they've got a pneumonia, giving them antibiotics. If they've got fluid overload, diuresing them. And then going forward, looking at long-term definitive treatment, whether it's on discharge or ongoing as an inpatient, but you'll need to address that eventually. So we'll go through a few cases to try and illustrate the approach to the patient with shortness of breath and the different ways they can present. Our first case is Mrs. CB. She's a 76-year-old female, and she presented with worsening shortness of breath on minimal exertion over the last 2 days. She had a gradual onset of this shortness of breath and has been having progressively worse exercise tolerance, where usually she would have no issues walking up the stairs. She can't even walk to the bathroom on flat ground without getting short of breath. She's had a few episodes like this in the past, and she does have a known history of ischemic heart disease, with an echo showing a left ventricular ejection fraction of 55%. And she's on some medications in keeping with her extensive cardiac history. However, you'd note that she's not on everything you'd expect someone with heart failure necessarily to be on, so she may still be being worked up for that. In terms of her social history, she's a non-smoker, lives with her husband, so she's got some support at home, and is usually independent of her activities of daily living, but is finding it more difficult because of the shortness of breath, and that's quite important to ascertain how her presentation is affecting her quality of life. And she is on a fluid restriction at home, 1.5 liters. So on examination, you find she's quite alert. She is speaking full sentences, but she is needing some accessory muscle use to breathe. She's afebrile, a bit hypertensive. That may be her normal. You would have to check that. And she is not saturating very well on room air. You find her JVP is elevated. Her heart sounds are dual. Her chest, you listen to it, and there are widespread bilateral crepitations, and some pitting edema to her mid-shin bilaterally. So I'd encourage you to stop here and just take a moment to think of your differentials given the history that we've been given and the examination findings you've gotten through, and use that to guide what investigations you're going to want. So basically, we've got a lady with an extensive cardiac history who presents with a gradual progressive shortness of breath and signs of fluid overload. So what we are thinking here is possible acute pulmonary edema secondary to heart failure, but it's important not to jump straight to that, even though the history and examination might be quite telling. It's unlikely to be an infective cause. She's afebrile and hasn't been coughing any sputum up, Given that it wasn't a sudden onset, it's less likely to be a PE or tension pneumothorax. She's coming in as an outpatient, so there's not really a good reason why it should be an atelectasis. It could be pleural effusion. There would need to be an underlying cause for that, but it's quite possible. So just keep in mind that even though it might seem quite clear-cut, it's important to not rule out anything else. And so hopefully you've thought of the investigations you'd like to order, and they line up with this. So you'd want to get an ECG, and it shows no abnormalities, basically. A urinalysis, which you do to check for any urinary tract infection, is quite normal. And you do bloods. ABG is normal. Her full blood count shows a bit of an anemia, but not no raised white cells, so no infection as we can see. Her renal function's a bit impaired. Again, you'd have to check that with her baseline. She may have already had impaired renal function If not, that would be something you'd need to investigate further as well. And it's important to check renal function if you're planning on diuresing the patient as well, as furosemide can impair it further. Do some troponins, which are raised but downtrending, and they're stable since the last admission, and we know she's gotten a history of ischemic heart disease, so this is not a surprise. It's mainly you would do that to check that she hasn't had an acute event that would have precipitated this presentation. And you'd also do a NT-proBNP to check for heart failure. And she may have had that before, and then you could see those results. So just have a think again of what stands out more in the context of the history, investigations, and examination findings that you've encountered so far. Again, APO is seeming quite likely in the context of her current presentation. It's less likely in MI now that you've done the troponins and an ECG. Her presentation isn't really in keeping with the cardiac tamponade. And similarly, go through the respiratory causes. As we mentioned, the PE, the tension pneumothorax, there would be a more sudden onset. This could be a presentation of COPD, even though she doesn't have an existing diagnosis of that. Could be a non-infective presentation, as we've seen that she doesn't really have signs of an infection. It's possible she could have pleural effusions and underlying malignancy. Or again, it could be due to other causes, so she might have ascites from another underlying cause. And the last thing you should really think of is a presentation caused by anxiety. It's really important to rule out all the other organic causes before you jump to this conclusion. And so having that in mind, you've done your bedside tests, you've done your blood tests, think of the imaging you'd want to order, and if you said chest x-ray, that would be a very good start. So this is her chest x-ray, and I think you'll go through reading chest x-rays in a separate lecture, so feel free to pause it here and try and practice what you would have learned. But as you can see, it's quite congested, she's quite fluid overloaded, there's some redistribution to the apices, some perihilar congestion, not much in the way of pleural effusions. There are some curly B lines, and the heart size is slightly enlarged. And that's just a schematic diagram of the changes, X-ray changes that you could expect to see in someone with acute pulmonary edema. And so having diagnosed an acute pulmonary edema in this lady, we'd move on to her initial management, which would involve oxygenation. She's desaturating on room air, so we want to give her some supplemental oxygen, give nasal prongs as she seems quite well at the moment. If she was a bit less well, might consider high flow nasal prongs or non-invasive ventilation, so CPAP, if she was really struggling to breathe. So again, that's your assessment of how well or unwell they look will guide your management. We'd want to get the fluid off her lungs, so we'd diurese with furosemide and position them upright to improve their lung compliance as well. And finally, not forgetting to identify the underlying cause of their presentation, whether it's non-compliance with their fluid restrictions, whether it's their hypertension, and you'll need to treat that as it's not being managed well, outside? Have they had an arrhythmia, etc. So just not to forget that the APO has an underlying cause and is not the beginning and end of this patient's presentation. So moving on to our next case, Mr. FK. He's a 67-year-old male presenting with 1 week of nausea, vomiting, cough, breathlessness, and fever. So a whole host of things happening there. He was previously well before this occurred, and he's had a gradual onset of his shortness of breath from 3 days ago. He's had some fevers and a productive cough where he's brought up some green sputum. No real chest pain. He denies any coryzal symptoms and any other associated symptoms as well. And he's a non-smoker, lives alone, and is quite active around the house. On your examination, you find that he's febrile. He's requiring some oxygen. He is able to speak in full sentences and quite alert. You find when you auscultate his chest that there's some reduced air entry to the right lower to mid zones. And not much else remarkable on his examination. So again, think of what your differentials might be in this case, and use that to guide what investigations you would order. Given that he's febrile, you would want to do a septic screen, so do your blood cultures, especially before you start giving antibiotics. Look for a focal source of infection, so do your urinalysis, checking for your UTIs and urine culture. Do sputum cultures if he's bringing up sputum, which he is. Do some respiratory swabs as he's got some respiratory symptoms, and then investigate as you would normally with ECG, full blood count, EUCs, ABGs. Just again making sure you can justify all your investigations. So you find on the bloods that you've sent off that his white cell count is quite elevated. All the other investigations are normal. You wouldn't get your cultures back for a while, but you've sent them off, which is good. And then you'd want to get your chest x-ray. So again, considering your differentials and what might be more to the top of your list and what you can consider less likely. So he's got a signs of an infection, pneumonia or respiratory tract infection would be at the top of your list. It could be a first presentation of COPD. It could be something else with an infection superimposed on that. So you could have a UTI and concurrent pneumothorax or a concurrent APO at the same time. So just remember that things aren't as cut and dry in real life as they are in the textbook. So it's important that you don't rule anything out before you've done all the investigations that you can, and before you've had a clear cause for their presentation, because people can present with a multitude of different things, and that really throws your direction. So just consider everything. You do a chest x-ray as well, and as you can see, there's a distinct patch of consolidation in the right lung, which corresponds to your examination findings. So we think Mr. FK has pneumonia, and importantly with pneumonia, you'd want to consider whether it's community acquired or hospital acquired, or a bit more rarely aspiration pneumonia. So if they haven't been in hospital for 48 hours, treat as a community acquired pneumonia, and it just affects your management in terms of your antibiotics and what kind of pathogens you're wanting to cover. And you can use a couple of scales like SmartCop and Curb 65 to determine the severity of the pneumonia and how you can manage them going forward, whether it's as an outpatient or whether they'll need inpatient management or whether they will need intensive care. And so these are the two scales that I was speaking about. So they basically both look at factors that would predispose to a more severe disease and use that to guide your management forward. So in the Curb 65, if they only have one or none of those risk factors that you see there, so if they're fairly young and they're not they're hemodynamically stable and they're not neurologically confused or drowsy and such, you can consider just sending them home with some antibiotics to be treated as an outpatient and reduce unnecessary admissions. And the things that you can do as you're seeing them, you can give them oxygen to improve their saturations, and for pneumonia, treating them with the appropriate antibiotics. So moving on, we've got our third case, Miss SR. She's a 69-year-old female, and she's had a prolonged hospital admission for a complicated procedure on the background of colorectal cancer, and she's had a very slow, prolonged recovery. She'd had a sudden onset of shortness of breath and palpitations while she was mobilizing with assistance to the bathroom in her hospital bedroom. And she also had a syncopal episode when she tried to mobilize back into bed. And in terms of her past medical history, she has the malignancy, the colorectal adenocarcinoma, and that was the cause of her presentation, this admission. And she also has type 2 diabetes. And that's just what we've talked about before. So again, considering your differentials, and we've spoken about that already. In considering whether you proceed with a CTPA or getting a D-dimer to rule out a PE, you'd use your Wells score criteria. So basically considering their risk factors for a PE, whether they have current clinical signs and symptoms of a DVT, whether you're suspecting PE as your number one diagnosis based on their presentation, their history and examination, whether they're tachycardic, or if they've been immobilized for a long period of time or recent surgery, if they've had previous thromboembolism, hemoptysis, or malignancy. And adding up all of these, you can use MD-Calc or you can just do it the old school way. For Our Lady, she has a Wells score of 10, so you definitely would go for imaging to find the PE or to rule it out or to rule it in, etc. She's quite unstable, so we'd probably go for an echo rather than a CTPA. And if your suspicion is less than, if your Wells score is less than or equal to 4, a PE is considered unlikely, so you'd consider doing a D-dimer to rule out a PE if it was negative. And if it was positive, you'd have to consider further investigations, because won't necessarily be raised from the PE. It could be a different cause. And if you're considering doing a D-dimer, also look at the PERC rule, which will help you identify if it's quite a low clinical probability of a PE, and therefore you don't need to or consider not investigating it further to avoid unnecessary investigations. And so, given this lady is quite unwell, focus on your initial management and resuscitation. So whether she needs oxygenation and or ventilation, if she needs fluid resuscitation, though if they're as unwell as this lady, you'd want to make sure you assess her heart function with the echo that you would probably get before you decide to give any fluids and put further strain on the heart. Also empiric anticoagulation, and this will depend on their risk of bleeding versus your suspicion of a PE, and thrombolysis or embolectomy if indicated. But just note that by this point you would be calling for help and not managing this by yourself. So you would have guidance and not be making these larger scale decisions on your own. And just a quick look at the long-term management of your PE. Alright, so our fourth case, we've got Mr. BG, who's presenting with a 2-day history of worsening shortness of breath on exertion. He's also got some fatigue and a productive cough with some green sputum. He does have a known history of COPD, and he does present quite regularly to the hospital. He's not a CO2 retainer. He's on a couple of puffers. Socially, he is still smoking quite significant amounts. He does live with his son and granddaughters, and these have been sick with a viral illness, so he does have some sick contacts. But he's quite a well 56-year-old, so he's quite independent. On examination, you find that he's febrile, he's not saturating quite well, he generally appears quite unwell, and you hear some wheezing and crepitations in his chest. His investigations show raised inflammatory markers, and his ABG shows some hypoxemia and respiratory acidosis. So again, considering your differentials, obviously given his history of COPD, we'd wonder if this was an infective exacerbation of a COPD, but again, as always, not ruling out anything else until you're able to establish a definitive diagnosis. So you've done your bloods, you've got an ECG, which is quite normal. You do a chest x-ray. You can see what you'd expect in COPD is some hyperinflation. You don't see any focus of consolidation, which might indicate an overlying pneumonia. No lesions that might be suspicious of a malignancy. Could be a little bit congested. He might have some fluid in his lungs. So when someone comes in with an exacerbation of their COPD, give them oxygen, usually aim for saturations of 88 to 92%. And it's important that you do consider if they are a CO2 retainer, just the amount and the level of oxygen you're giving them, but that you're not afraid to actually give them oxygen, because likely they will still need it. Antibiotics, if it's an infective presentation. Our guy is febrile, so we would give him appropriate antibiotics. Oral steroids, usually prednisone, and a weaning regimen. Give them Ventolin as needed, and can also give them non-invasive ventilation to assist with lung compliance. And importantly, with COPD patients, being a chronic disease, it's really important to review their current treatment plan, so their current medications or puffers. Are they on the appropriate amount? Are they on the right types for their current disease severity, or has it gone downhill and they'll need a reevaluation of their medications? Also look at preventing recurrent hospitalizations in the future, so encouraging them to get their flu vaccines and pneumococcal vaccines. Encourage smoking cessation every time that you see them, even if you know it might go in one ear and out the other. It's important to just keep mentioning it as many times as possible, and also looking at pulmonary rehabilitation. And with assessing the severity of COPD, importantly look at the GOLD criteria, which combines their level of symptomatology with the amount they have exacerbations or hospital presentations, and ensuring that they're on the right puffers for their level of severity. And this is just a reminder of the overarching ongoing management of a patient with COPD. All right, so our final case, Mr. AA. He's a 61-year-old male, day 1 post-laparoscopic nephrectomy on the left side. He's had a decreasing oxygen saturations on room air from 96 to 94, which isn't a huge decrease, but it's something the nurses have come to ask you to review. And so after being given some oxygen, there's still no improvement in his saturations. They've dropped a little lower to 93%. He's not very symptomatic. He has some mild pain around the surgical site, which is to be expected, but otherwise he seems quite well and he's not really complaining of anything. On your examination, again, you see that he's quite well. He's speaking full sentences. He's perfusing well. His trachea is not deviated, but you listen to his chest and you find some breath sounds are present in the right lung, but completely absent throughout the left lung. And percuss and find that the left side of the chest is resonant to percussion. And heart sounds are a bit muffled and difficult to hear. And he's got some mild pitting edema to the mid-shin. And so you do a chest x-ray and find this, in case that wasn't glaringly obvious. You can see on the left side that he's got quite a large pneumothorax with no mediastinal shift, so it's not a tension pneumothorax. And with this, as with everything, consider if they're stable or unstable. Go through your airways, breathing, circulation, and stop at the one that needs management as you go along. So checking their airways. If their airways aren't patent, doing your head tilt and jaw thrust. Checking their breathing. If they need oxygen, give it to them then and there. Listening to their chest as you've done. Checking their perfusion, their circulation. And if you did find a tension pneumothorax, which shouldn't be something you find on an x-ray. It should be something you can see clinically, then going for that needle decompression. And if they're stable, depending on the actual size of the pneumothorax, you'd try and insert a chest drain in the area of the pneumothorax. And usually depends on which guidelines you see. I think some European or American guidelines, one uses 2 centimeters and the other uses 3 centimeters. And we don't have to go through all of this, but this is just another reminder to consider the underlying cause for presentation of the pneumothorax. And those were the resources used. Good luck, and feel free to contact me with any questions or needing any help.